This podcast represents my opinion and the opinion of my guests. This is not medical advice, and I am not establishing a patient-physician relationship with any listener. The content here should not be taken as medical advice. The content here is for informational purposes only, and because each patient is so unique, please consult your healthcare professional for any medical questions you may have.
Welcome back, everyone, to another episode of the Not Your Doc podcast. I'm Vanessa. I'm here with our producer, Seth. We're in the Midwest Institute for Hearts and Minds studios, of course, and we're back again with Mr. Not Your Doc himself, Dr. Charles Tadros.
Yeah, get it right. Get it right.
Sorry.
I want to make sure my titles are correct.
I've only said it a few times.
Hi, everybody.
We are back with another very exciting guest today. Dr. Tadros has just been absolutely killing it with getting some great experts on to speak to us about healthcare related matters that affect all of us. Today we're going to talk about heart, cardiology, heart health.
Yep.
We all have hearts. So Dr. Tadros, please take it away and introduce your guest to us.
Yeah, sure. Hi, George. To my right is George Kichura. George just talked to us a few minutes about his background, but what he didn't say is that I came to know George because I inherited his clinic at John F. Kennedy Clinic at Mercy whenever I became an intern, and he was a few years ahead of me. So he handed off a nice set of patients that were well cared for whenever I was just right out of med school trying to figure out how to do things correctly.
I never would have guessed that he's older than you.
So, yeah.
Sorry.
George is interventional cardiologist and clinical lipidologist. Lipidologist means cholesterol for the rest of us commoners here in St. Louis, and he works at the St. Louis Heart and Vascular. He's a partner there. He's also principal investigator and sub-investigator at St. Louis Heart and Vascular and the Department of Research. George has more board certifications than I know how to pronounce. He's board certified because he's unlike a lot of docs who are subspecialized, who let go of their general internal medicine. He's a true internist by training. He's an internal medicine and board certified, and also in cardiovascular disease as a cardiologist and other peripheral and other vascular disease. An interventional cardiologist, that means cardiac caths and stents and peripheral valve placements, et cetera. And a lipidologist, that's the cholesterol panel stuff that we all were going to talk about today. He has a few dozen other things that qualify him to hang out with us, but he didn't even need a fraction of these to come. He's always welcome here with us. Welcome, George.
Well, thank you. Thank you, Chuck.
Thanks for coming this time. George is still in his scrubs because he's a working man, even though his kids are extremely successful, and so is his wife. George continues to work as if there's no tomorrow. So he's a good role model for the rest of us who are goofing off like I am.
Yeah, absolutely.
George, I'm gonna pass it off to Vanessa to start us off, but we're going to talk about a variety of things, but mainly primary, secondary cardiovascular disease prevention. This is preventing heart attacks, the first heart attacks, and if you've had a first heart attack, how to prevent a second one. And this stuff also applies to strokes and peripheral vascular disease typically. So it's bigger than that, but we're gonna try to focus on that.
Yeah, absolutely. All right, primary prevention. Take it away, Dr. Kichura.
What is it?
What is it? How do we do it?
Yeah, what are we preventing exactly?
Yeah, please.
So the first thing to realize is the process, the disease process, is called atherosclerosis. And all that is, a way to think about that is it's just kind of a buildup inside the artery walls, whether it's your heart, in your head, or in your legs, or anywhere in the body, because the arteries are kind of the pathway that bring the blood and oxygen and the nutrients to your different cells throughout the body. But atherosclerosis is this process of building up plaque inside the artery. It changes the artery. And that plaque can develop as early as your teenage years, sometimes even earlier.
That's right.
And it can progress over the course of your lifetime. And most people would say, well, I really don't care if I have this because if it doesn't cause me a problem, why should I care?
I don't feel it.
So it's one of those disease processes that if it doesn't cause you a problem, I really don't care if I have it.
Out of sight, out of mind.
Exactly.
Yeah.
So
is plaque the direct result of what you're eating? How does plaque accumulate? Where does it come from?
That's a great question. It tends to occur at points of turbulence of blood flow, at branches, and at certain parts of the artery, whether again in the heart, the legs, or in the head, or carotid arteries in the neck. And it can occur. We don't know why it occurs at those particular points, but we do know that there tends to be more turbulence in those areas. And whether that is a stimulant to create the process going on inside the artery wall, that's a kind of a simplistic understanding of why it occurs there.
So let me jump back because I'm points of clarification. George knows what he's talking about. I just need to catch up. I grew up old days, arteriosclerosis versus atherosclerosis. Arteriosclerosis is an old term. Is it for bigger arteries or macro stuff?
So the arteriosclerosis is more implied, kind of more of like a fibrosis or more of a constriction because the arteries can get stiff or not, but when we're talking about atherosclerosis, it implies atheroma or this atherosclerosis or the plaque buildup, again, inside the artery wall, which can then change the architecture. And then if it grows to the extent of blocking the blood flow 70% or more, it tends to cause symptoms when if someone is demanding more blood flow with exertion or doing a specific activity, they may not be able to deliver that because of this fixed obstruction from the atherosclerosis.
So people tend to, and I'll just correct me, people tend to think like carpenters and plumbers. They tend to they picture things. So they picture out of your heart, the size of your fist, that sits in the middle of your chest. Comes this big aorta. But that's not what we're talking about right now. We're talking about the stuff that feeds the heart muscles. The heart inside of it has blood that it pumps elsewhere through this aorta, but actually right outside the heart are branches that go back into the surface of the heart, epicardial vessels. That these are coronary arteries that are about the size. What are they? 4 millimeters? What are the size of the vessels on top of the heart, outside of the heart, that feed the heart muscle itself that cause heart attacks?
Yeah. So there's variations depending on the main channel or branches, but it can range. The main channel, the left main, can actually be very large in diameter, sometimes 6 millimeters or more.
The real human being, 6 millimeters is the size of a pencil.
A pencil eraser.
Pencil eraser is
like
6 millimeters.
Okay.
Yeah.
So that for George, this is big. The rest of us humanoids, it's nothing. It's nothing. But but this is the level we're talking about whenever it comes to the widowmakers and killing and people dying. This is the stuff that builds up in the arteries of a 6 millimeter. This is the biggest artery that feeds the heart muscle itself directly, is about 6 millimeters.
Right, and then as that main artery divides, it gets smaller gradually.
Divides, right.
And it can be 2.5 to 4 millimeters most of the time.
Yeah. So we're down to a pencil. We're down to a pencil lead, or the whenever you sharpen a pencil. Nobody sharpens pencils anymore.
Point.
Yeah, it's the point and actually to a little wider of the point. Yeah. Okay.
Right. And then if you want to make the analogy of being a plumber, being inside the pipes.
Yes.
You're looking at the accumulation of the junk, basically, that's obstructing the flow down the pipe. Right. Yeah. And it doesn't cause you a problem until it blocks the pipe enough.
Sure.
Now my pipes, if I cut open the pipe, I can see it. But this is different in the arteries because it's not on the surface or the inside surface. It actually gets stuck in the meat of the pipe. Right.
Right. It starts in the inner wall of the intima, and basically continues to grow inside that section, but also it starts to get into the lumen or the inside of the artery or the pipe, where then it can obstruct some flow.
We're waving our hands, but people can't see. George is very good with his descriptions, but it's almost forms a blister that's pointing inside into the artery, blocking flow.
Right. And
it's not a blister with air. It's a blister of fatty material. Right. If we were to cut it open like pathologists do, it looks kind of a yellowish, whitish material.
Yes, and the reason for that is that it's filled with usually oxidized cholesterol or
Yes.
LDL, bad cholesterol, lousy L
Right.
is
There you
the
go.
bad stuff. And as there's more and more of that, these plaques can also get thin-walled, and part of that can make it vulnerable, meaning
Yes.
that it can like lift up off the artery wall, which can then cause the body to look at that like it's a cut, and it will try to seal it by creating a clot. And if it does that, it shuts off the blood flow
Very
and
quickly.
That's what a heart attack is.
Wow.
So I want to make sure, because George is giving us gold here. I use the word gold too frequently. So inside your 6 millimeter or 4 millimeter artery, it feeds the muscle, the heart muscle itself. You'll get a blister of fat-filled blister that pokes inside where the blood flow is. But that's not enough to restrict it. Sometimes 70% restriction. That's when George goes in with his heart catheterization to look at it and do some stuff with it. But sometimes this cap or the surface of this blister, some of it's thinned, especially in the edges, and sometimes it cracks. So you'll get a fracture of the plaque. And whenever you fracture the plaque, it exposes this fatty, yellowish, whitish stuff to the bloodstream. And then the bloodstream decides it's going to use all those platelets and some of the other proteins that your liver makes in terms of clotting. And it goes from this fatty plaque that's kind of sealed away, and then it cracks, and all of a sudden the bloodstream plugs off the remaining part of the open artery with a clot, an acute clot.
Yes.
And so that's the final event that ends up people in the emergency rooms, hopefully.
Right. So that, unfortunately, is still the most common cause for death in cardiovascular
Yes.
disease is basically a cardiovascular event or heart attack.
Right.
Half the people never make it to the hospital.
And I think it's important. Back when we were medical students, it was still half the people didn't make it to the hospital. 40 years later, 35 years later, half the people are still not making it out of the hospital.
It's still not making it
To the hospital.
The
To
hospital.
even to the
They
hospital.
make it out.
Right.
They don't make it to
So-
in many
Wow.
cases.
So this is a number that I have a hard time believing after how much training, how good you are with your hands.
The reason why they're not getting to the hospital,
Yes.
though, is because either people are ignoring their symptoms
Yes.
and waiting, and then
Right.
they have an arrhythmia as a result of this blockage in the artery and have a sudden death.
Yes.
Or the people around the person that has the event are not trained in CPR, and they're
Right.
not able to rescue them
Right.
in order to give them a chance to survive to
Yes.
get to the hospital. So
And that's
that's
part of-
why there's still a lot of work that needs to be done to get the communities
Yes.
and people trained in CPR, especially if you have relatives or friends that you're going to be around that potentially this could happen to them without warning.
And George actually spent part of his career and his life actually trying to improve the system, the first responder system here in St. Missouri. Is that
Yes,
right?
yes.
And we're going to come back to that because George does everything from primary prevention, which is what we're talking about here, to prevent the arteries from clogging and then the fractured plaque, and and to the point where he can also go in and open up these arteries, get rid of the clot and crush and open up the plaque, the closed off artery. But there's a big range of stuff. But half the people never make it to your table, your cath table.
Correct.
Yeah.
Right. So, so the key here is getting to the hospital
Right.
as little time as possible, whether it's through the 911 system or through. We tend not to recommend people driving their
Zero,
loved
yes. Of
ones, but there's always this question. Oh, but I'm not sure it's my heart.
Right.
And so they feel almost bad or guilty if they
embarrassed,
use
right.
911 when they shouldn't.
Right.
That's right.
There should be very low threshold if they're having symptoms that as chest pain specifically in men. But women
Right.
sometimes can present with atypical symptoms.
We're going to come back to
we're
that.
and we'll
definitely
get
gonna
back
ask
to
about
that in
Yes,
more
that's a
in
big deal by
detail.
itself.
Yeah.
Yeah, and that's so we are very good in a lot of hospitals throughout the country now. Back 30 years ago, 35 years ago, we were very new with blood clot busting agents, the streptokinase and the TPA. But now we progressed now to plasties and balloons that just open up the arteries, and now we put stents in. And so we've kind of progressed over the last 40 years in my career and your career to very advanced stuff that really saves myocardium. This is the whole idea is to save lives, but also save heart muscle.
Yeah. So to give you an idea what Chuck's talking about, the paper, the thrombolytic paper for treating heart attacks came out right when I was leaving medical school and starting residency. And so that was our way of initially treating these patients. What we've learned after many trials of doing what we call direct balloon angioplasty and stenting eventually is that you can actually get better outcomes by opening the blood flow by using a balloon that pushes that plaque back up against the wall and then restores blood flow down to the rest of the artery. And then what we've learned after that is that process as it heals can recur and re-narrow. So stents were developed which basically scaffolds or opens or keeps that artery open after you do balloon angioplasty. And that reduced the re-narrowing rate over 6 months, for example, from 40% to 20%. Right. And then further improvements occurred over the years where medications were added to the coating of the stent. So we call it drug-eluting stents, which is predominantly what we put in now, which also interferes with the re-narrowing process as the artery heals. And so that re-narrowing rate is now reduced to under 10% in 6 months. So it's dramatic improvements. And so, first of all, your risk of survival, you're getting through this heart attack today is so much better than what it was 20, 30 years ago.
Yeah, within our practice lifetime.
Yes.
Yeah.
Without a doubt.
So this restenosis, I know we're deep in the woods here. This restenosis is not another clot, it's not cholesterol. It's actually scar tissue that squeezes down. Is that correct? Because it's within 30 days.
So the two things that would lead to re-narrowing is first recoil. And that recoil is eliminated by a stent. And then the restenosis or the healing process is more of a proliferation of the cells coming in, and it re-narrows as it heals.
Gotcha, yes.
Because everything heals with inflammation.
Right.
Most things in six to 8 weeks.
That's right. If you think of a skin cut, right.
Yes, exactly. And that's true with anything biologically, so it's the same process.
I know we're deep in the weeds here, and it's hard to describe this stuff, and I'm very interested always in this because of how dramatic we've been from ballooning to stenting to drug-eluting stents. So let's get back to how to why people don't make it into the hospital, and then how to prevent them from even having the first event, so they don't have to make it into the hospital.
Yes.
And once again, I everything is of interest to me. I'm not a good judge. I'm not a good judge of direction of conversations because I love everything that you say. So. What got us to this point in the United States? It's still the number one killer in the United States. Is it in the world? No. Is it in the world? Is it the number one? Is coronary artery disease in the developed world probably?
Yes, it still is.
So, I mean, this has been going on for decades and decades, despite all the research and all the money. This has been going on forever. So why are we still in this quandary? And we've done all sorts of stuff. I feel we're nibbling away at the edges. We talk about a little bit of cholesterol and better weight control and exercise and blood sugar control and diabetics, but we're still deep in the crap. So
let's start with after you've had your event. Okay, we know that first of all there's a high recurrence rate of having another event, and it's about 20% if you do nothing. Okay.
So it's after one.
So 1 in 5 people, one in 5 who've had a stent, or just say who've had a heart attack.
Okay.
1 in 5 will have a recurrent event. 20% in a year.
Wow.
Very high. That number can be reduced multiple times in half by adding certain medications like aspirin, like another antiplatelet agent, whether it's clopidogrel, Brilinta, or there's different ones. It can be reduced by taking a beta blocker.
Okay, after myocardial infarction, yes.
It can be reduced by taking a statin. And there are other agents now that can reduce it even further, which I don't want to get too much into the weeds.
That's right.
So if you look at that, someone usually presents, they've never had a problem with their health, and all of a sudden they're coming into the hospital with a new event, a heart attack. They have on no medications, and they go home on 4 or 5 medications.
That's right.
And that's like a shock to everyone.
It is. It's a big deal.
But they all reduce that recurrence rate
Right.
from 20% way to single digits. Okay. And everything else we do is trying to reduce that risk even further.
Right.
Now, in addition to that, there's higher risk individuals
Yes, those are very special
that we want
subsets.
to exactly
Those are
that
very
we want to
ones,
be even more aggressive
Right.
with
Because
because they're having repetitive events.
Right.
They're having another heart attack and another one.
Yeah, these are special subset of people that are more than 20% risk of
Yes.
another
Yes.
myocardial infarction within a year.
Yes, and there's a lot of many clinical things we've identified that puts them in that category. So first of all, having a heart attack makes you higher risk.
First heart attack gives you second heart attack risk.
Right. And having multiple heart attacks and having a recent heart attack versus one that was a couple years ago. And then there's all the other risk factors
Right.
which become part of the primary prevention, which I'll get into. So you have whether or not people are smoking, because the smoking can lead to more damage to the artery, can lead to more disease, it can lead to more events.
Yes.
So smoking cessation is extremely important,
Yep.
both primarily and secondarily.
Always. My father has smoked before his first heart attack and went back to smoking after his fourth heart attack and never had another heart attack but had heart failure. But yes, he went back to smoking. Yeah.
Yeah. And second thing is hypertension or blood
Yes.
pressure elevation.
Yes,
So
absolutely.
many people are out there, they don't know they have high blood
Absolutely.
pressure. They come into the office, many people, and have what we call white coat hypertension,
Right.
meaning that they see our white coat as a doctor and
They're
they
stressed
get
out.
stressed and
Yeah.
their pressure goes up and
Right.
they think, oh, it's just because I'm here.
Right.
And so
I'm being tested.
yes,
Or
so
because I
that's
walked up 2 flights of stairs to get into the office. Yeah.
right. So there's more and more of an effort to first of all monitor blood pressure outside the
Outside
office
the
setting,
office,
whether
yes.
it's ambulatory blood pressure or
Right.
remote blood pressure monitoring.
Yes, that's right.
And then you can determine whether you're treating them or not treating them. The other interesting side fact is if you haven't been diagnosed with hypertension by age 50, the word supposedly is that there's almost 100% likelihood that you will be diagnosed in your lifetime.
Wow.
It's very sobering.
Yeah.
It's
It really is.
coming. It's coming. Just
Right.
because I haven't found it, it's still coming. If you're going to live for another 30 years after 50, which is the average, you're going to still develop it. Yeah.
Okay. So, and I can get into why that matters, but I don't want to get
All
too
of it
far into
matters,
the
yeah.
weeds. But the third thing is this issue of LDL,
Yes.
which again is the lousy cholesterol, L for lousy.
The higher, in general, the higher, the worse potential for increased risk for atherosclerosis or
Right.
this atheroma inside your artery.
And the range here, everyone gets many people get their cholesterol checked by their doctor.
Right.
And I always ask them, well, what were the results? And almost 90% of the time, they told me
it was
my
okay.
results were fine.
Fine.
Yeah.
It was okay.
I have
That's
no
right.
idea what that means.
We don't know. Yeah, that's right.
And it's a different number depending
on
on
your
your
risk
overall
factors.
risk.
Right. That's right.
And so I'm constantly always trying to redefine what their true risk is.
That's correct, because most of them don't think they needs to be that low.
Right.
Both the primary care doctors or the patient think that they're okay enough, that even if they're on a statin. But
Right.
anyway, yeah.
So one clear message, I definitely want to make here or say here is know your numbers.
That's right.
You need to know your blood pressure.
Amen.
You need to know what your cholesterol is,
Amen.
especially your LDL.
Yep.
All right. Because you can have something called familial hypercholesterolemia, which is more of a genetic problem with cholesterol, and you frequently will see that there's a family history for premature disease, having disease in their 40s or
Yep.
30s in some cases.
Men less than 50 and women less than 60.
Yes,
age.
and I can tell you stories of women presenting, and we'll get into that again, I know,
Yep.
but women presenting to the emergency room with
Yes.
chest pain and dismissed
That's right.
Right.
because they're too young
Their
to
30s
have
or 40s. Yeah.
blocked arteries, but that's not true anymore.
Yeah.
Okay,
Right.
so knowing your cholesterol number is very important. All right. And then if you have disease, vascular disease or atherosclerosis, really determines whether or not you should be aggressively treating your number.
Okay.
Okay. So there's many guidelines, and these guidelines have evolved over the years. In 2018, there was the last major multi-society guideline that most people are following. But then there was a consensus guideline that came out in 2022, and this is even more aggressive for the high-risk patients, that their target LDL should be under 55. Okay. So why?
What's the target LDL for someone who has not had a heart event and who
Great
doesn't have
question.
a significant family history?
Great question. So again, it depends on so in what you just defined, they don't have known vascular disease. You can plug them into these cohort risk equations, which you can find online. Plug in your numbers, your blood pressure, your numbers, and it will spit out a 10-year cardiovascular risk.
This is Reynolds risk score in Framingham.
Reynolds includes some other information.
Yes,
it includes inflammation and family history.
Highly sensitive CRP. That's correct.
But the others, these others are based on cohort data, not only Framingham, but other cohort data, and that's been the best predictor for knowing what your true risk is.
10-year risk,
right? If it's 7.5% for 10 years, then you should be getting treated with a statin.
So let's make sure 7.5% risk of a major cardiovascular event. This is a stroke, heart attack, or bypass or stent. Over the next 10 years, if it's 7.5% risk or worse, 8%, 9%, 10%, then you should be on a statin. This is primary prevention.
Yes.
And again, the variable inputs that go into that are cholesterol, blood pressure, age, sex.
Right.
What other determinants go into that?
That's pretty much it. So a lot of these are age driven.
That's right.
So if you're younger and all of a sudden you turn 50, your risk goes up like dramatically overnight.
Right.
But that in and of itself, there's other risk parameters that I will check as a lipidologist. I'll check something called a cardio IQ, or you could do these advanced lipid panels, whatever company you use, which gives you a lot of other information, particle numbers, ApoB, LP(a), inflammation markers, things that can also be used to predict your risk outside of the formulas.
Right. Okay.
And then there's also lifetime risk. So if you're looking at this and you're young, but you have a higher lifetime risk, you might still initiate a statin at an earlier stage.
Because what happens to these formulas is that if you are very young and you have a very high lipids, your youth will cancel out and you won't achieve the requisite 7.5% or worse in order to start a statin. But if your lifetime risk is still high, then it's worthwhile. If your cholesterol is 300 whenever you're 25, then it's still worthwhile to get on a statin depending on what this lifetime risk shows. Okay, thank you.
So if let's say you have familial hypercholesterolemia, you have a very high risk over your lifetime for having an event. You're like 50 times.
Is it that much?
Yes.
Wow.
But the belief is that if you treat that LDL, which is going to be above 190 or greater, and you treat that to below 100, you can actually get on a natural history path of someone who doesn't have the disease.
Somebody who's never had lipid problems or familial and is not on a statin, you can bring the high-risk person down with the help of a statin to that level of risk.
And in a similar way, we also, if they're very young and yet let's say they're 5% risk and they're plugging them in their equation, you might get additional information by getting a calcium score test.
Yeah.
And what this does basically is if you have a 0 score, all right, you have way less than 1% risk for a heart attack in the next 10 years. So if you were like 30, 39, 40, and you got you're very, very low risk for 10 years. That's a kind of a comforting thing to do.
Yeah, absolutely.
I did it in my 40s.
Yeah.
And I did it in my 60s. And I was luckily a 0 in both cases. And yet I still have some of these other markers. And as a result, I take cholesterol medicine for that reason.
So what was the name of that calcium?
Calcium scoring. So it's a
Calcium
CT,
scoring.
it's a CAT scan that basically looks for calcified plaque
in
the coronary arteries.
Sometimes your internist will look at it as a coronary artery calcium score or CT calcium score.
Okay. And then we were talking about the formula, essentially. What did you call that, Dr. Tadros?
There's one. It's Framingham. It's named after a place in Connecticut. It's called the Framingham, and I don't know. It's the
so you can put in risk cohort, COHORT.
Okay.
Yeah, and that
we're going to
will
put
find
links
it.
to these
We'll
things on in the podcast description, so people can find this, because I didn't know any of this stuff existed. It's incredible.
So again, first identifying what their real risk is with the LDL. Okay, there's. And I'll get into more detail here in a second, but there's really 8 things that can influence your risk for whether it's a recurrent event, for secondary prevention, or if it's for that first event where you don't want to have that first event.
Right. They're both. So these are all good preventers across the board.
Right.
Okay.
So we mentioned smoking, we mentioned high blood pressure, we mentioned cholesterol. The others are blood sugar. So whether you're diabetic, or whether you have a blood sugar above 100 but not at diabetic levels of 127 or higher,
Right.
you might still have insulin resistance, and
That's right.
some people actually call it stage 1 diabetes.
Okay.
Some people call it prediabetes, and some people ignore it. Okay,
They shouldn't.
but you shouldn't. All right, because it does attribute more risk.
That's right.
All right. Then there's what we call body mass index. And, the definitions there is that if you're 30 to 40, you're obese. If you're over 40, you're morbidly obese.
That's right.
And if you're not at 25 or less, between 25 and 30, you're considered overweight, but you got
That's
some work to do. So what we know there is that if you... and that is defined, your body mass index is basically how tall you are, what your weight is, and your body surface area, and it's plugged in and you get a number.
That's right.
And we measure that every time someone comes in for an office visit.
Your software does it for you whenever you get your height and weight in there. Yes.
So part of that then comes to what is a healthy diet and an activity level of 150 minutes or more a week, moderate activity. And then we can get into other things of is how well you sleep at night. So whether you have sleep apnea or whether you snore, you stop breathing, and which puts you at risk for a lot of other problems besides another cardiovascular event, arrhythmias and problems in the lungs and problems with the heart function and so on. But I don't want to get too far off on a tangent here. And
6.
So smoking, hypertension, LDL, glucose, BMI, dietary health, activity
level,
and sleep. That's
so
8.
That's 8. Those are, so we used to call life simple 7. Sleep was added. It makes it the essential 8.
Essential 8.
And that I focus on every time I see a patient, whether it's for primary prevention to assess their risk for a first event, or whether they're back from after an intervention and we're trying to reduce their risk for another event.
Gotcha.
Okay. For the people I have stented many, many years ago, when stents first came out in the 90s, I have people that I did multi-vessel stenting on. I have a lot of people that I did all these. For those that followed those 7 things and they reached all the targets, none of them have had any recurrent events.
Wow.
Okay? And I mean, this is a way of knowing that you're doing everything you can to modify your risk. So essentially they had normal lives beyond that because they follow this. Now, only 2% of adults meet all those criteria.
Wow.
So there's always something to talk about when they come in. Always. All right.
Yeah.
So and back to cholesterol, just to get into a little more detail there. So if they had an event, if they had a heart attack, our new target is going to end up being under 55.
Okay.
For their LDL.
For the LDL.
So they'll usually get started on a statin. They'll usually get started, or they may get started on other agents to get them to that target. So depending on where they're starting from with their LDL, they may or may not get there.
Right. That's correct.
So some important information is if you look at the different systems in St. Louis, or if you look across the country, it doesn't matter. The data is the same. After one year after having an event, ACS event, a STEMI, non-STEMI, heart attack, only 50% of people are getting to the targets. And that's before the more aggressive target came out.
Okay,
so it's
wow.
it's even more than that now.
It's going to be harder. It's going to be harder to achieve, right?
So the point is, and that's the most modifiable risk factor is your cholesterol. Now the downside of this is there's still a lot of people who are very against statins. Okay, they think every ache and pain that they feel after starting a statin is from the medicine, then they won't take it. Now I'll tell you this. That yes, you can get myalgias or muscle aches. It may be higher than what they initially thought and what they were reporting. And that was about, it is now about 15 to 20% of the time that they will get that. And there are different strategies for how you dose it, which ones to use to avoid that as a side effect and yet get the benefit of the statin. Okay.
And statins are still, we have a bunch of other lipid-lowering agents, but statins are by far the most studied and the ones that show the best results so far.
Yeah, so this kind of brings me back to the early 90s.
Yes.
The first grand rounds I gave was the 4S trial, which was the outcomes trial with simvastatin for patients. And the cardiologists at the hospital at the time were not treating cholesterol.
Wow.
And even after I gave the grand rounds, which basically showed that there was better outcomes by treating these LDLs with a statin, there was still a very long delay before that was adopted. And what we're seeing now is we know that aggressive lowering of LDL has numerous benefits.
It's not just lowering,
and yet there's some resistance and barriers for people to get there.
It's not just lowering. We're targeting this target because until recently, until this consensus paper. It was the target for after one event was less than 70. The LDL was it less than 70? Is that right? Before we got down to 55?
Yes.
Is that right? So and back then the strongest and most potent was Zocor, simvastatin back then, and eventually it was Lipitor and Crestor and some other ones. So even despite the tools that we had. And some of the good, well-run, not every study is well-run, but the well-run studies that people were having resistance. It's more work, it's more responsibility, it's more follow-up, it's more medicine, it's more everything. But this is the problem we were running into and some people don't want to. They just want to pass it back to the primary care or whatever. But we now know that if you're in the hospital getting a stent or stuff like that, that they need to discharge you on these medicines in order for you to be able to continue on, because things tend to get dropped if you were discharged. That's part of the quality.
Yes, and to further that point that you make, we know that you start accruing recurrent events after that first heart attack over the course of that year. It starts as early as 3 months. And unfortunately, the LDLs or the cholesterol is not being checked soon after their hospitalization. And that needs to be checked earlier and earlier. So I'm trying to really get that message out as well.
This is basic stuff. I mean, you do very fancy, expensive, high-tech stuff, but this is basic. This is basically administrative stuff. Are you on a stat? Are you on a beta blocker? Have you seen a dietitian? Are you walking? All that stuff. These are very basic. This is not rocket science. But we have to do it consistently over months to years, because it's not just a one-time thing and you're done. This is over and over again for chronic. These are chronic conditions.
Now, the other point I would make is that you're not going to get everyone to target with the statin.
Right.
So there are going to be other agents added, and the most recent push has been again with these what we call PCSK9 inhibitors.
Right. These are injectables?
These are injectables. There is an oral one that was developed. It was shown to be effective at lowering LDL. There's no outcomes trial. It's still going to be studied, so we don't have an oral one available yet. There's also a company that's trying to do genetic knockouts.
Oh.
So you can actually maybe, if we get to that point, change that so you'll never develop any PCSK9 and your LDLs will never go up, which means the atherosclerosis process may not even occur.
Interesting.
So this may be a potential cure in the future, but it's way too early to say, this is going to happen in the next 5 or 10 years. That's all I'll say at this point.
We want to differentiate what George is talking about. And this is the problem with drug companies. They'll come out and tell you lipid-lowering percentages, and they'll compare it to other lipid-lowering agents for superiority. But what they don't always have is outcomes data. So just because your numbers go down, your LDL reaches targets, doesn't mean that the mechanism that got down there is going to help you prevent you from a heart attack or stroke or death. So this is a big, big difference, because the FDA allows you to come out and put out a product that that shows that it lowers certain numbers, but it doesn't necessarily does not have to show morbidity and mortality improvement, right? That's the outcome stuff that we're talking about. That's what you and I are really interested in. It's nice to see numbers go down, whether it's blood sugars, whatever, but we want to make sure that we prevent strokes, heart attacks, kidney failure, all that stuff that we're trying to target.
That's absolutely true. So to expand on that notion, one of the PCSK9 inhibitors was used in patients who were post-ACS, who have had a heart attack, and they had imaging done inside the artery, which basically identified the plaque, looked at the cholesterol arc, looked at the thickness of the plaque, and then they were treated or not treated with one of these agents. And what they saw when they re-looked at those arteries is that plaque morphology had changed with that agent. The amount of lipid had decreased, and the thickening. There was thickening of the cap.
So this is all positive. This is stuff.
This may be why the outcomes for this particular agent is more beneficial, and this may be the mechanism of why.
So what George just described is regression of a plaque by decreasing the lipid, the yellow, white, fatty stuff. And not only that, it stabilized the cap. The cap is the stuff that cracks, and it allows the bloodstream to see it, and all of a sudden all the platelets clot, and then that's an acute heart attack. So what George described was not the end product, but I showed that the mechanism was in action that we want to see, that we picture is the beneficial step before preventing a stroke or heart attack, is that the regression of this atheroma.
Exactly.
Yeah.
So the effort, whether there's mild atherosclerosis, and you're just trying to prevent that first event, or whether it's secondary atherosclerosis. Again, the point being is, do we really care if we have it, as long as we stabilize what we have and it doesn't cause us another event? And it doesn't cause us symptoms or limit our life in any way with symptoms.
That's only a determination you can make based on the outcomes.
Exactly.
Yeah.
So that's what George just described as being able to live with chronic disease that doesn't seem to progress to cause injury, morbidity, or mortality, which is a different thought process. This is how we think about
it altogether,
right. Then reversing that, then curing you in the sense that that you never have to see a doctor, never have to take a pill. So it's very interesting stuff. This is a kind of a chronic disease model where we're going to improve you so that you can continue life, not necessarily cure you, but we can stabilize things so you can enjoy your life. Yeah.
Can we talk some now about diet?
Yep.
Yes.
I want to understand what the role of diet is with regard to cholesterol.
Okay, so back to our essential 8, kind of diet and BMI and our activity level are all tied together, and they generally run together. The diet, when people have a BMI over 30, and most of my patients do, the first message I have is, we know that if you do lose 10% of your body weight, you will lower your risk.
Okay.
So what I usually do is
not your body weight, but your excess body weight. Is this 10%?
So, well, just from where you're starting.
Oh,
I'm not getting to a final goal.
Right.
I'm getting to a reduction in risk.
So if you start at 280, losing 28 pounds.
Exactly.
28 pounds.
Exactly.
Okay. So it's not just the excess weight, but it's just the extra of the total weight. 10% down from the total weight. Gotcha.
Yes.
Okay. Thank
and
you.
the way the formula that seems to work is you get to your target, which would be say 250 in the case you give, and then you multiply by 10. That would be 2,500 calories to maintain that.
Okay.
But then you subtract 300. So you would want to follow a 2,200 calorie diet in someone who is 280, and you want to burn 300 calories every day.
Okay.
You would lose about 2 pounds a week.
Okay.
And over 3 months, you would get down 10%, just like we planned.
Okay.
People follow this. It works.
All right,
If you cheat on the weekend, you stop it a couple days, and you binge or something else, or you didn't get those 300 calories, it's all about the reduction over time.
Sure.
So
it doesn't come off, and then that's how it works.
So to say, all right, math problem, everybody.
Calories in, calories out.
Take out both pencils. So start it again. So we're going to go. Let's pretend
Pick a weight.
Pick a weight. 200. Let's pretend 280 pounds. Is that all right? Is that
Okay.
280 pounds. So we're going to want to.
You want to lose 28 pounds.
Okay, we should make it even. Let's start at 200 pounds for us common folk that don't want to carry the one here. So 200 pounds. So we're going to lose 10%.
You want to lose 20 pounds.
Minus 20 pounds. That's right.
All right.
So it'll be 180 now is your total weight.
Correct.
All right. And that then we want to take that 180 multiplied by 10.
Yes.
And that equals how many calories per day
to maintain
180, which is still not our target, but that's what we so 1,800 calories.
Yeah.
And then we want to subtract 300 calories because
we're trying to get a 600 calorie a day deficit.
Okay. So so minus 300 which gives us 1,500 calories per day.
Yep.
All right, so that's just input, that's intake. So the 1,500 intake, and that's 300 calories times 7 days is 2,100 calories, which is about a pound a week.
No,
So it's
you have to subtract the 300 you're burning,
and then you want to do another subtract. So you want to actually 1,500 calories, but we want to subtract
you
another.
Consume 1,500, burn 300.
Another 300. So
3,500 calories is a pound.
Right.
So you're going to do a little more than that. Right. Some people will lose 1 pound a week. Some will lose 2 pounds a week.
Right.
When you follow this kind of formula, but you have to do it consistently, and you're not dropping your calorie intake so drastically like so many of these
that
diets.
You go into starvation.
Right. Yeah, because it doesn't. Your body adjusts, and then you don't burn. It changes metabolism.
Right.
All right, so that's one thing that works.
Okay. If
you look at what works for your lipids and what works for your risk, the Mediterranean diet works. You have we know that keto diets actually can lead to worse lipids. So
despite weight loss,
despite the effectiveness of losing weight.
Right.
But most of the time, we're recommending the Mediterranean diet.
Yeah, it's been shown several years running that it may be the healthiest.
And so the main thing is you want to avoid animal fats. You can go, vegetarian if you feel so inclined. Dean Ornish many years ago tried to promote that. The problem is not a lot of people can follow it and get into the meditation and the exercise and all the things that went along with that in order to be successful for plaque regression, weight loss, and risk reduction. But it works if you can do it.
Dean Ornish, back in the late 70s, early 80s, showed with cardiac cath that he regressed lesions in coronary artery disease purely on within a few months purely on this vegan. It's a vegan diet, really. I don't think it's even vegetarian. It's vegan. It's like no animal product, no butter, no milk, no eggs, and stuff like that.
So what I like to at least take away from that, if people are still into eating, it's always a question of do you live to eat or eat to live?
Well, okay.
And I like food. I'll be honest with you.
So do I.
So what's some sensible advice? So my mom always told me moderation, which I think is a very good thing. That is true to this day.
Yeah, still works.
And I think if you're going to eat beef, having it once a week. That's it. So what are your other protein sources? It might be chicken. It might be fish. Different fishes are better than others.
Eggs, legumes.
Eggs and all that. And there's really not a limit to how you can only have so many eggs a week and all that. That's not, I find that to be nonsense. The bottom line is you need to get protein sources as part of your diet that you like, that will keep you satiated, so that you can avoid reaching for anything with sugar and high carbs, and that's going to work against you.
Right, absolutely.
Yeah.
So that if you follow those principles, it works.
Yeah.
It really does work.
Very rarely do you hear cardiologists talk about satiation and hunger and stuff, because that's the reality. That's the reality of everyday life, is that if you're hungry, you're stressed, you're gonna reach for whatever you satisfies, so you can keep working or doing whatever you're supposed to be doing.
Yeah. If it's unsatisfying, it's going to be unsustainable.
Yeah, it's not as sustainable either, right?
Yeah. Now, just to be complete, there's a big push now about these injectables for weight loss.
Oh yes.
So we were actually involved in many of these trials for both the diabetic and the non-diabetic.
Interesting.
And I think Hollywood got wind of this.
Oh yes, they did.
And
It
led to a shortage of the problem for the problem. And now, not only what happened after that is there became a company that was formulating it.
Oh, they were compounding it.
They were compounding it, and they're selling it cheap. And you don't know. We have no outcomes. We don't know about safety. We don't know anything. Now they'll say, "Oh, it's just the pharmaceutical companies trying to make their money." No, I would be very hesitant, and I can tell you that this is out there. It's on the internet. So I would be very reluctant to do that.
Compounding of injectables is fraught with. It's got to be super specific, very clean, very tightly controlled. It's fraught with tons and tons of problems. Infections, fungi, spores, all sorts of stuff that people have never heard of. It's a humongous problem. Yeah.
So even though these agents are effective, especially in diabetics, it reduces cardiovascular risk. It leads to weight loss, many times 30 or more pounds.
Yes, it works.
And it is effective at losing weight in non-diabetics.
Right.
There's really no low hypoglycemic reactions.
Right.
They claim there's really no risk for the thyroid cancer.
Yeah, the medullary thyroid carcinomas.
Even though there's caution in MENs if there's a history for MENs.
Yeah.
And
multiple endocrine neoplasia.
Yeah. So. But what they also know is that if you stop using it, you can gain the weight back.
Everything comes back.
Like all these other diets.
Everything.
But Hollywood is still doing it. A lot of people are doing it. They're losing weight with it, and basically it takes away your appetite. You don't want to eat as much, so your calorie intake is less.
It decreases
you end up losing weight.
It decreases gut motility, and so it makes you feel satisfied for longer. So therefore, you tend to eat less. But like anything, if you stop exercise, you gain weight back. If you stop your dietary changes, you gain weight back. With these shots, you gain
and there's
weight back.
Questions about whether it affects your muscles too. Sure. It's not clear yet, and there's still there's more investigations going on. But the message here is I was amazed when I found out that there was these compounding.
It's a problem.
It's chasing a dollar. Basically.
Well, it is, and they're remote. It's not your local doctor, and so the people on the phone or online, they'll prescribe it for you because they're doctors somewhere that they hired out to talk to you over the phone or whatever and get your information, and that they can quote unquote legally prescribe it, which is a humongous problem.
Right.
We should talk about briefly bariatric surgery. We're going to extremes. Bariatric surgery is quite helpful in terms of decreasing the risk for becoming diabetic or helping you reduce your blood sugars. If you are a diabetic, if you qualify for bariatric surgery. Back in the 70s, whenever we used to put balloons in people's stomachs and they eroded through it, that we're much better at things now. So any person who's been suffering with morbid obesity, certainly with obesity, especially with diabetes or several risk factors, bariatric surgery should be on the table. It may not be what you want, et cetera, but it should be discussed. I find a lot of physicians don't want to bring it up because they're embarrassed to say you're so overweight that you may die, and therefore let's do something extreme like surgery. A lot of it's laparoscopic. Not everything causes a dumping syndrome and malabsorption, which is one of the big problems we had with some of the aggressive stuff that did help people lose 80 pounds and 110 pounds with the Roux-en-Y and some of the other ones. But do you have experience with the people that have had?
So I've had at least 10 patients who have had bariatric surgery. Usually their BMIs are much higher.
Yes.
And they've tried to lose weight, and they're frequently told to lose weight before they'll even do the surgery.
That's correct.
They'll typically lose 80 to 100 pounds.
Yes.
They sometimes gain a little back, but
That's right.
by and large, I'm frequently taking them off blood pressure medicines and cholesterol medicines and other things because all their numbers improve
Yes.
Great.
after the surgery.
It's not a cure all because I followed these people for years afterwards. They tend to regain maybe 40% of their weight back, not 80 or 100% of their weight back, but it's it's dramatic. And then over 4 years, 5 years, almost no matter what procedure, they'll gain quite a good chunk of it back, not more than 50%. But it is life saving, and that's what we're at the level we're talking about here.
I think it's funny how our conversation is sort of going to come back to the beginning, which is symptoms of heart attack.
Yep.
I think that's sort of a good place to kind of like
Always.
end the discussion, is so people understand what the symptoms are, what they should do in the event that they're experiencing these symptoms. I hope you can also mention too why heart attack symptoms are so often missed or dismissed in women, particularly,
And diabetics
Yes.
too. And
Yeah.
diabetics.
Yes.
Yeah.
So let's
Absolutely.
start.
And not only that, but the false, whenever they do come for a testing, that we still miss it even on treadmills and other things like that. That's another,
Yes.
we have layers of problems despite modern medicine. And even if people do catch it to come in and talk about it. Anyway, good.
Great. Okay. So as you know, traditionally, many of these studies were done predominantly in white males.
Men's,
Yes.
Yeah.
And that's improving now, but there's still a very lack of
Yes.
look in both
So studies
African American,
examining what the
Hispanics, and women.
symptoms and
Yeah.
presentation of heart event are. Okay.
all,
right,
car-
yeah.
all,
Heart attack.
all the cardiovascular
Okay,
studies.
okay.
Yeah, it's improving. But,
Yeah.
but let me say this: the traditional way a male will present would be with chest pain.
Okay.
And it's usually, if it's angina, there's a lot of different ways people say it, is usually exertion related, and it's relieved by rest.
Okay.
Okay. And it can be described as pressure. It can be described as a squeezing. There's something called the Levine sign where someone puts their fist to their chest, and that usually suggests that it's cardiac as a cause. But again, it's relieved by rest. It
Okay.
stops. If you take a nitroglycerin, some people have those because they have a prior history, that might relieve the discomfort within 5 minutes. Sometimes it takes 2, and it's within 10 minutes.
2 pills.
Okay.
2
But with a heart
nitroglycerin pills.
attack, first of all, the pain doesn't go away, and it's not necessarily exertion related.
Okay.
It may have occurred with you sitting in a chair, and it just started, but it's not going away. And you may get other associated symptoms with that. You may be perspiring. You might be short of breath. You might feel a little nauseated. Okay. You might have feeling like an indigestion with it. Okay. That's kind of the classic way it presents.
So the first set, which is what we call stable angina, you exert yourself going up the stairs or carrying something, and you get chest discomforts, chest pains, jaw pains, and then you stop and it goes away in a few minutes. That's stable angina. It's still coronary artery disease. It's still atheromal cholesterol built up in the artery, but that's not an immediate emergency typically because it goes away whenever you rest.
Correct.
The second one is a medical emergency, which is the oftentimes central chest pain. Could be jaw pain down the arm, sweats, nausea, vomiting, sometimes dizziness. That doesn't go away. That's an emergency.
Yes.
Okay.
So
good.
when we say doesn't go away, how long do you give this? How long do you try and rest?
Right. So if it's someone with known disease, they have plaque or they have moderate narrowing or something from a
Or
prior
family history or
evaluation,
something like that? Yeah, okay.
then you would say to try the nitroglycerin. If they don't have it or if it's lasting, I would say more than 10, 15 minutes, they need to call 911.
Okay.
Yeah. Now, there's some other things we try to ask. Is it pleuritic, meaning is it worse with deep breathing? Is it radiating or traveling anywhere, down your arm, up your neck? Some people have bizarre descriptions.
Sure.
That sometimes it goes to the right side. Sometimes the most bizarre heart attack I've ever seen is somebody who presented with discomfort in the third finger of their left hand.
Yep.
And that's it. No chest pain, no neck pain, nothing else.
I had somebody wake up at night with the wrist pain, literally just that it was his wrist pain.
And how do we know that it was a heart? Because they came in and they had an EKG done, and we can see changes that tell us it's a heart attack.
Acute heart attack, right?
Wow. Okay.
All right. So that being said, that's the typical way. So maybe 10, 15 minutes.
Okay.
I wouldn't spend the night at home
No.
waiting for it to go away.
Yeah.
If I wake up in the middle of the night and it's not gone after I'm sitting up for 15 minutes, wake up your significant other and say, hey, I think there's a problem here.
Right.
And then call 911. If you have, let's say a lot of times young people will present a couple days after exercising, and then all of a sudden they decided they were going to start an exercise program. They're doing some bench presses or push-ups or something different.
P90X
all of a sudden, oh my chest is killing me. It hurts.
Me. Right.
All right. And it happens 2 days after they started something 2 days ago. Again, there's ways to get at that question, but I wouldn't use that as a reason to not get evaluated.
Yeah.
All right.
Because soreness typically would be the next morning.
Yes.
Right? But 2 days later, we would not think it would be soreness starting then.
Sometimes it can as you get older, but not beyond 2 days.
Not beyond 2 days. Yeah. So after that, so then we have to think it may be something else besides soreness from starting an exercise.
Right. And that might be reproducible if you push on the chest. It might be worse if you take a breath, you feel it more.
Yep.
And
so would that be an indicator that's muscle related
Right.
and not heart related?
It might be.
It's confusing because
that's
heart is the muscle.
Right. Because you don't want to be wrong. That's
exactly.
Point.
Of course.
And then sometimes when the GI sometimes will tell people to take Tums and just pop a couple Tums, and if it goes away, then more likely it was something GI, maybe like esophageal spasm or reflux, versus a heart attack.
Yeah,
because that's not going to help heart pain.
Right.
Okay, so that's the typical way.
The typical white male presentation.
Yes.
Okay. All right.
And they don't usually like to go, and they're usually prompted to go by their significant other. They're usually the driver of their health care. Yeah.
So women can get this too, but this is typically men. Yes, that's correct.
Okay.
Middle-aged and older men.
Now, women, on the other hand, they present with more atypical symptoms.
Yeah.
Non-typical, yeah.
All right, so they may not get the chest pain, pressure, and all that. They might get indigestion or shortness of breath. When they exert themselves, they get short of breath. Sometimes that's what we call an anginal equivalent. Yeah. All right. If it was a heart attack, it would be at rest, so it wouldn't be exertional. But a lot of times they'll present with indigestion or shortness of breath when they come to the emergency room or when they call 911 and they're brought in. And then they get an EKG and they find out it's a heart attack when they see the changes on the EKG. But until the emergency rooms are directed that anything between the tip of the nose and the belly button can be a heart attack. Can be a heart attack.
Okay. Yeah.
And the best way to discriminate or find out what that is get an EKG early.
Yeah. Right.
So if you're sitting in the waiting room and you come in and they have you sitting out there telling, look, I'm concerned I might have having a heart attack.
Yep.
You'll get an EKG right away, and then that can help you find out right away if it's really a heart attack or not.
Okay.
So what George is saying, and George is very clear, but from the nose to the belly button includes jaw pain, neck pain, chest pain, belly discomforts. It could be pain, it could be bloating. One of the problems we run into is people have indigestion, and this is the problem. They're worried that they're going to be calling 911 and stuff like that and going for some tummy upset because they had, it could be a gallbladder, it's true, it could be a pancreas, it could be all sorts of stuff. But the problem is we can't differentiate it at home.
Yeah.
And that's the problem that we have, is that we can't do this over the phone or at home very often, especially for women who don't necessarily have a history before that. The other thing is that women tend to, because unlike men who have a woman next to them, I hate to be sexist, a woman next to them say, let's go. The man is typically not waking up in the middle of the night and saying to the woman, let's go.
Yeah,
so it's not tit for tat. It's not even Steven here in terms of people supporting each other.
Sure.
And so the other piece, which is George, is shortness of breath. And this is a problem. We're overweight. We have reflux. We have asthma. We're weekend warriors. We're raking. All of a sudden, shortness of breath is a big sign for men and women. Exertional shortness of breath needs to be addressed, and some of it needs to be addressed acutely, like this. It doesn't seem to want to go. And George reinforces that you're not exerting your heart, you're not stressing your heart,
right.
And it's not going away. That's that's an emergency, right?
I think you mentioned before with indigestion, a woman presenting with indigestion being dismissed as a GI symptom. So can you, as a patient advocating for yourself, can you insist, I need an EKG?
Yes,
I want you to do an EKG.
I would definitely do that.
Yeah.
And so the other point that I'd like to make with women, again, because they haven't been in a lot of these trials in the past, again, they're thought not to have heart problems.
Right.
And so they're under-tested, they're under-evaluated, and they're many times oftenly mistakenly dismissed. And, if they could get in and, if let's say it was an exertional symptom, if it's happened when they're doing something physically, they don't have it at rest. We talked about the stress test. That would be a way to evaluate that, for example, in the office. Typically, we're going to do a stress test. And the bad part there, from my perspective, is we know a plain treadmill stress test is not a good discriminator whether it's ischemic pain or whether it's from blocked arteries for women.
So jump back and say what a treadmill stress test is.
So you have somebody walking on the treadmill, and then you're monitoring their blood pressure, their heart rate, their EKG as they are exercising. And you're looking for any changes or any symptoms with the exercise.
So you're looking for both symptoms that she let's say, talk about a female patient. She was saying, I'm short of breath, or I have jaw pain or arm pain or whatever. And you're looking at the EKG, and you're looking at the pulse, and you're looking at the blood pressure. You're looking at all these 4 parameters, what she says, subjective, and all the objective parameters.
Right.
Right.
And to make it a, quote, positive test, meaning that we think there may be blocked arteries as the cause for your symptoms, we're looking for certain changes on the EKG as you're exercising. Okay. So what we also know is that these changes are not as specific and sensitive for women who do plain treadmill stress tests. So we do get that specificity and sensitivity, or the ability to say it is or it isn't, with adding imaging, nuclear study. The problem is the insurance companies don't want to pay for it.
It's more expensive to add radioactive material.
So we're often doing these plain treadmill tests to satisfy the insurance companies when we really haven't answered the question. And so there's a constant battle between the cardiologists and the insurance companies about paying for a nuclear stress test.
This has been going on for decades. This has been going on for decades. That the insurance will say, if there's no resting EKG abnormality, that we want a basic treadmill, or non-specific resting EKG abnormality, we want a basic treadmill on this female. And then if she has an equivocal treadmill test, then they'll have another treadmill with imaging. Is that correct?
Correct.
And is imaging still include stress echo?
That would be one way. If they have good images at rest, and you're looking for changes in the function as they exercise. So you get an echo looking at the heart function both before exercise and then at peak exercise, or at the time when you think you need to stop. And you're looking for changes there as a diagnosis for blocked arteries.
So we're looking, when we say imaging, we're talking echo, we're assessing maybe some sort of nuclear tracer that looks at heart muscle ischemia, lack of blood flow to certain parts of the heart muscle that shows up differently. It actually looks like a picture of a glowing heart, and so certain areas will not glow whenever it doesn't have radioactive tracer that goes to it, because there's not enough blood supply to it, because the woman's having problems. So, but these are more sophisticated tests, more expensive tests. And insurance tortures us.
Just another message. So what the stress test is looking for is getting symptoms or EKG changes and if that occurs, that implies that there's a 70% or greater blocked artery.
Okay.
Doesn't tell you whether you have atherosclerosis or mild blockage.
Okay.
And that's an important point because some people will have a stress test and it was fine. And then they leave the office, they go home, and they told them the stress test was fine.
Normal, right.
And then they have a heart attack the next week.
Yeah.
Well, how could that be?
Yeah.
It's because that mild plaque became
That's right.
unstable,
Sure.
That's right.
blocked the artery
Right.
like we talked about
Sudden
earlier.
event.
And that's the difference. So that's how you can have a normal stress test and still have a heart attack
Yeah.
a week later.
Sure.
So I mean, what George is saying, and because he does this for a living, he knows this automatically. But what people don't understand about every test, and Vanessa and I have talked about this on previous podcasts, every test has limitations. I don't care if it's a mammogram or if it's a stress test. Whenever people tell you it's normal or it's nothing, there's no cause found, does not necessarily mean that you don't have heart disease or you don't have potential for cancer, for breast cancer, if it's a mammogram. So everything has to be taken into context with your physician. That's why you follow up with the physician after the test, whether by phone or stuff like that, saying I'm still having worries or I'm still having symptoms, even though you have a normal test. It doesn't mean that you're out in the cold by yourself. That there's other things that need to be done. And
The other point I'd like to make is women tend to have about a 10-year delay before they develop cardiovascular disease.
compared to men, compared to men.
And the reason it's thought to be the protective part. If unless you have a hysterectomy or
Sure.
then
Sure.
that protection goes away, and then you're on the natural history of a male
Okay.
for when you might get the disease.
Okay.
That being said, so that kind of is looked at as if you've had a hysterectomy at a younger age, that can be looked at as a risk factor for
So it's a surgical,
for
what we call
atherosclerosis.
surgical menopause. It's not just a hysterectomy. They take away your ovaries and you go through the change early.
Yep.
That seems to accelerate it and put you on a track like a man who's never, of course, had a significant estrogen production. Yeah.
And then the other things we know about women and heart disease is that in general, there'll be all this talk about the outcomes are maybe not as good in women, or maybe they don't want to have surgery, or they don't want to have a angioplasty or a stent.
Right.
And what it really comes from is, in general, women will have smaller arteries.
Okay.
And so the potential complexity may indicate there might be a slightly higher risk with both of those treatments, even
Okay.
though they're still the same treatments as what we would do in a male.
Okay. And so a solution to that would just be to develop better techniques and materials to accommodate women with smaller arteries.
Sure.
Okay, great.
Sure.
George, I mean,
delightful.
why is it women don't have crushing chest? I mean, why don't they have crushing chest pain like on average, like men do? I mean, what's
I
the
don't
difference?
know. I don't know the answer to that, but there is something called silent ischemia, where with diabetics and with hypertensive patients, where they may get these EKG changes
Right.
when they're ischemic, meaning not getting good blood flow when they're demanding it with the activity they're doing. And
Yeah, for
sorry, I lost
but
thought.
yeah, for why
Somebody
do
was walking by the window.
Sorry, why don't women have crushing chest? I mean, so it's fine. I mean, we're going to keep our ears peeled for shortness of breath and tiredness and exhaustion with exertion,
Right.
all that stuff. But
So
why
you
don't they?
So you can still get to what we call silent heart attacks.
Right,
is
right,
the point? Meaning
right.
you don't get that chest pain. You may get something different
Right.
in terms of how you're presenting with certain symptoms,
Right.
and so that has to be kept in mind whenever you're thinking about coronary disease in a female.
Skipping a little bit to diabetics, we'll talk about. There's type 1s or insulin requiring diabetics from early on in life, and then there's type 2s or adult onset. Some of them require insulin later in life. A lot of them are taking care of oral medications. Can you talk specifically, since 90% of diabetics in the United States are type 2 or adult onset, typically not initially requiring insulin, but usually diet, exercise, and pills. Now there's some shots that are not insulin that you can give them early on. Can you talk about these types of patients and why about the acceleration of heart disease, and also we tend to their silent ischemia?
Sure. So as you said, the majority by far are type 2 diabetics.
Right.
But yet I've treated heart attacks in type 1 and type 2 diabetics,
Sure.
putting stents in both, and they've done well.
Yeah.
The issue with putting stents for heart attacks and diabetics is they tend to have more diffuse, longer disease.
Yes.
They tend to have a more robust healing process,
the fibrosis
which can lead to more renarrowing unless you use the medicated stents.
Right. Yes.
They tend to have other risk factors besides the diabetes,
Right.
such as high blood pressure,
Right.
cholesterol issues, etc.
Right.
The good news is there's many agents that have been developed in the more recent years, and we were again part of these clinical trials that have been shown in diabetics to reduce their cardiovascular risk for not only recurrent events, but heart failure, for readmissions, etc. Medicines such as Jardiance, or you can go on and some of these other medicines that we spoke about earlier for weight loss as well.
Yeah, this crossover that diabetic medicines are preventing heart morbidity and mortality from cardiovascular disease.
Right.
Yeah.
So there's other agents for heart failure to reduce risk. For readmission and for getting worsening breathing issues and so on.
Yeah.
So there's a lot of good medicine out there. Unfortunately, some of that is still not always covered by insurance, and so
not for these
getting
conditions.
access to all of those other agents. But most of the agents we know that benefit you are generic and are available.
Yes.
And can really dramatically improve your outcomes and your course with these chronic diseases.
We have potent statins and beta blockers for $5 from Walmart. So yeah, with a prescription, but without insurance, we have some of the stuff that cardiologists need for you right there, and ACE inhibitors for blood pressure lowering. Wonderful. Yeah, thank you.
Absolutely. All right, so, just to sort of recap what action points we want people to take with this. Obviously, know your numbers. I think that was a really important part that you talked about. Again, speaks to the importance of having great primary care, having relationships with a primary care physician. So knowing your numbers, of course, the essential 8, those 8 behavioral modifications that immediately affect your health. Dr. Tadros, can you go through those again real quick?
Yeah, sure. Smoking and smoking cessation, hypertension control, LDL or which is your bad cholesterol, your oxidized LDL cholesterol reduction to target less than 55 if you're primary or secondary prevention. Glucose control if you're diabetic or pre-diabetic or insulin resistant. BMI, body mass index, which is your weight and obesity. Healthy diet. 150 minutes of walking. I'm way far away from that one. 150 minutes of walking or some sort of moderate activity per week.
Per week, yeah.
Yeehaw. And then sleep, the quality of your sleep.
Quality.
So which includes sleep apnea.
Yeah, absolutely. The couple other takeaways there, we're looking at your risk cohort. So that we'll definitely have a link to that. And that, of course, takes the inputs from your age, sex, blood pressure, cholesterol, and sort of calculates the risk of you having a major heart event in the next year. Can also calculate lifetime risk. And then there are indicators for whether or not you need to get on a statin or have other interventions to keep that risk down.
So it's not next year. There's a lifetime risk and there's a 10-year risk.
A 10-year risk.
Not a 1-year risk. That's right.
Yeah,
That's good.
thank you.
Yes, that's excellent.
And then a huge takeaway for women, I think, too, is that women and men don't necessarily present the same way with heart attack symptoms. Don't wait. Don't downplay shortness of breath or chest pain. And then, of course, once you get to an ER or call 911 or something, insisting on an EKG, especially if you're afraid that, this is something that, should be looked at and you don't want to be dismissed. Wow, just so much good stuff, Dr. Kichura. Thank you very much for sharing your wealth of knowledge and expertise with us.
I think we exhausted George. No, it's
totally
physically, but not mentally, because he's got decades more experience packed in his head. And he's being nice about downsizing everything so we can kind of put it in a little more than an hour here. Thank you, George.
Absolutely.
You're welcome.
He's another good guy, just a good doctor, just a good person to begin with, and a good doctor on top of it.
Well, thank you very much.
Thanks, George.
So, of course, if you want to give us some feedback, get involved with the pod, you can send us an email at notyourdocpod@gmail.com. Check us out at our website. That is notyourdoc.com. That, of course, has Dr. Tadros' original Not Your Doc blog, plus all of the episodes from both of our seasons. We're getting ready to wrap our second season here. The podcast will be available on Spotify and YouTube. We'll have links to some of these important resources that you can check out. I'm gonna have a baby in a couple of weeks, so it's gonna be a little.
You couldn't see it through. You couldn't see it through the podcast.
Can't see it through the podcast, but I am very pregnant right now, and we are gonna pick up again once I'm back in a few weeks. And thanks so much, guys. Thank you, Dr. Tadros. Thank you, Dr.
Have fun with the
Kichura.
baby.
Thank you. Thanks, Seth. I'm Vanessa. We'll see you next time.
Bye-bye. This previous podcast represents my opinions and the opinions of my guests. This is not medical advice, and I'm not establishing a physician-patient relationship with any listener. The content here should not be taken as medical advice. The content here is for informational purposes only, and because each patient is so unique, please consult your healthcare professional for any medical questions that you may have.